Thank you. My name is Nick Boyce-Cam, as you can see from the slide. I'm a consultant trauma and orthopaedic surgeon. I work at Cheshire, and I'm here alone, but I'm representing a group of about 15 to 20 people who've helped develop this. So I'll touch upon a bit about that later on. Just out of interest, has anyone heard of a virtual fracture clinic in the audience? Just one hand there. Two hands. Okay, interesting. Okay. So why change? Well, I've been a doctor now for some 20 years, and in orthopaedics, we've been doing this the same way for 20 years, so we haven't really moved on. And we hear about all the challenges facing the NHS, the financial resources, which are restrained, and are thinking about a better way of doing it, particularly focusing on the patient experience. So this is how we set about looking to change our fracture services, focusing on the patient, looking at their journey from the moment they arrive in the emergency department through to our fracture clinic and then beyond. And we want to look at a number of parameters, particularly about who was delivering that care, how it was being delivered, and how the patients were receiving it along the way, and whether they all needed to come and see us. So we looked at the evidence surrounding some of these injuries to help us decide if we could manage this better, and to look at the patient experience and see whether there could be better efficiency across the journey. Just to put it in context, our trust is relatively small. It covers a population around 300,000, but we're challenged in lots of areas, not least things like car parking. It's little matters like that which can make a massive difference to patient experience. So we looked at the best evidence, which has been evolving and has evolved, way beyond the 20 years that we've been doing this, but practice hasn't really changed with it. So this was a good opportunity to look to explore that. So how do we do it? As I said, we looked at the journey from the moment the patient arrived in ED, and for anybody who works in acute care settings, they'll realise that this is the pressure point of hospitals. Patients are often having to wait for a long period of time. If those patients need discussion with subspecialties such as orthopaedics, that can delay the process. So one of the first steps was to look at all the injury patterns that we see and develop a guidance for those injuries so that the staff in the emergency department would be better equipped on how to deliver that immediate point of care treatment. And not least the immediate point of care treatment for some of these injuries, it's definitive treatment. So I developed a protocol with the ED department. We got consensus between 12 orthopaedic surgeons, 20 ED consultants. It's not an easy task getting consensus amongst two, let alone that number. We then developed a business case, and this was possibly one of the most challenging aspects that I found about the whole process of delivering this package of care, is actually that the numbers need to add up, and I'll maybe touch upon that later on. And as we've heard along the way, the key to getting any successful transformation change is engaging with the staff. So the majority of our orthopaedic injuries that come through the emergency department that don't require admission come through our minor injuries, and that's predominantly nurse-led. So we engaged with the emergency nurse practitioners, explored what their thoughts were, and I think through this process they'd probably all agree that we've actually helped empower them, and I'll mention that a bit later on. The Trust were very keen that if we're going to be changing a process, that we had these safeguards in place to ensure that patients were being appropriately managed, and this just wasn't a way of getting rid of a lot of patients without providing them with appropriate care. So we put in a framework to ensure that that was going to deliver excellent care as well as the right care. We have a very good patient team at our hospital, and they've been integral in helping a lot of the aspects of this to make sure that it was patient-focused, patient-friendly, and that the resources that the patients need was available. Often we miss that as the clinicians. So we got patients involved, also the patient team, to develop new patient leaflets, patient posters, and other aspects to help them. And then finally, the IT software was really key for us as clinicians to make it work, to provide the safeguards, but also an audit tool for us to evaluate and assess how well we were doing, whether we were delivering anything that we set out to achieve. So that also helped with the robust governance, because it allowed us to assess whether or not there were any errors or issues as we went along. So lots of people, as I said, we had to get consensus amongst about 20 to 30 clinicians, which was not easy. But eventually we reached a consensus to devise the protocol and determine what injuries could and couldn't be seen. We looked at the evidence as well. And just to give a brief overview, some injuries that historically have always been coming from the emergency department to our fracture clinic can be managed at the point of the initial care and never need any further specialist input, because they'll go on to heal with either splints or boots without the need for any special intervention. So we were looking to try and particularly address that cohort of patients as well as manage the other patients. As I said, there was a business case involved, and that was the main challenge in getting this through, and it took a good 18 months to 2 years to achieve that because of that aspect. But we also had to involve the commissioners, and all the staff along the way as well as the patients. So very simply, if I use a patient who attends with, say, a fracture of their forearm bone, if this is a child and we know that it's in a good position from the initial x-ray, the likelihood is that that will go on to heal without the need for us to do either further x-rays or further plaster casts or further appointments. But historically, that patient would have been seen in the emergency department, a break in the bone would have been identified, and they would have been seen back in our clinic maybe 2 to 3 times. So now what we look to do is those type of injuries, of which we've derived 8 to 9 patient sets, will be managed appropriately by the ED staff, predominantly the MPs. They'll be given the information, a patient information leaflet, and also a phone call, which is a phone number which is manned by our team during the day, and a means to contact us should there be any issues. The ED departments will apply the protocols, and then the patients will either be admitted, discharged, or all patients go to the virtual fracture clinic. Previously, the patients were booked in from ED into our fracture clinic, and that could mean a delay of sometimes 8 to 10 days before we'd be seen. So one of our goals was to make sure that not only the patients were being given the correct treatment initially, but also being seen by the right specialist at the right time frame as well. And there's new national guidance in for our orthopaedic body, which says that patients should be seen within 72 hours with these injuries. So this was a means to address that. And I'll talk a bit about some of the findings we have. So when I introduced this to my colleagues, I think they thought we'd all be able to go off on a beach somewhere and sit and relax. Sadly, when I gave the overview, this was obviously not possible, but the way it works is it's done every weekday, so that allows us to capture patients within the 72-hour framework. We haven't expanded to weekend running as yet, we haven't needed to. Any patient that's been seen in the ED department that hasn't already been discharged appropriately by the nurse practitioners has their notes and x-rays reviewed. And normally when we would see a patient in a fracture clinic, we'd maybe be able to see about 4 an hour. By doing it through this system, we can see some 36 an hour. So it really allows us to efficiently stream that patient care. Every patient is given a diagnosis by us, an outcome, and every patient is reviewed by a consultant, which is pretty much unheard of. When we were doing this before, it was about 40% or less than that we're seeing a consultant. The patients are given a phone call, so everyone is contacted, and they're given an appointment time and allowed to change it accordingly with the specialty as needed. The patients are also, the GPs are also informed with a GP letter. So when we looked at this, we looked at the different stages along the way and also how the patients valued the service. We found that overall, of all the patients coming to the emergency department, about 25% less were being referred through to us at all. So just by applying those protocols in the initial setting, 25% of patients were being discharged with either splints, boots, advice to return, and appropriate information. So those patients were not needing to come to our clinic at all. Of the patients that then further came through to our clinic, a further 20% were being discharged. So when they're being seen by the specialist, who can identify the injury patterns, whether or not they need to be seen, a further 20% are being discharged. And one of the issues that we'd seen before is that patients were being booked in by the emergency department into a clinic, but it wasn't necessarily seeing the correct specialist. And I think we've all become more specialised over the years, and it was probably time for us to change. So now the person seeing the patient is the correct specialist, be that a hand surgeon, a knee surgeon, shoulder surgeon, etc. And a further 3% of patients were able to review virtually. So we give the patient an x-ray form, a digital x-ray form, and tell them to come back in a week's time, call us once they've had it done, and we will review the x-ray to ensure that the position of any break has not changed. Interestingly, and this was something the managers really liked, was that our did not attend rate reduced as well. So because we're giving patients an appointment, telling them, and giving it at a convenient time, we found that our DNA rate decreased to 2% from previously 5%. And as I mentioned before, the guidelines that we have to review patients within 72 hours has improved from around 87%, whereas previously it was only 11%. But the most important thing, as we've heard all today, is ensuring the patient experience is good. I don't have the results up on the screen from this, but our rates of satisfaction were around 60% before. Our clinics were heaving and patients were having to wait a long time, and subsequently we found that our patient experience has improved. So it has spread across our hospital and also surrounding hospitals. This is not unique, it's spreading across the orthopaedic fraternity, but I think certainly the virtual clinic model, as we've heard from, or certainly I've seen some of the other presentations, is certainly a scope for the future for making better care for the patient at the right time by the right clinician. Thank you. Any questions?